Thank you. So we're going to shift gears a little bit and talk about some of the really nitty-gritty sort of practical considerations around implementing safe firearm storage counseling into clinical practice. My name is Dorothy Novick. I'm a pediatrician at the Children's Hospital of Philadelphia and a member of our Center for Violence Prevention. And I implemented a safe firearm storage program in our primary care centers in Philadelphia about a year ago now. We're in the process of expanding it. So I thought it'd be helpful to share some of the lessons that we've learned. Sorry, I have a little bit of laryngitis, so if my voice dropped out, that's why. So I'm going to share some information that we've learned for others who are interested in doing something similar in their practices. I'm going to try. There we go. So as Kelly mentioned, we definitely know many studies have shown that healthcare provider counseling around safe firearm storage is effective. And as Kelly mentioned, also studies show that we can be the most effective when we offer a safety device at the point of care. So for our primary care intervention, our goals were to, number one, increase the rates at which we screen for the presence of firearms in the places where our children, our patients live and play, and also to increase safe storage practices by offering gun safety education as well as cable locks at the point of care. We piloted our program in our 3-city practices. We started with our newborn visits only as a way to roll out the process, and are in the process now of expanding up to the older ages that Kelly mentioned. It's so important to do this work as well, and also out across our entire network. So when we talk about firearm storage with families, there's several really important things to keep in mind. And all these guidelines, I would say, are based really entirely on the specific barriers that Kelly has already mentioned that can really impede a productive conversation. So the first one is to always incorporate any conversation around firearm safety into our general safety discussion. As Kelly mentioned, one of the real concerns on the part of firearm owners is that the healthcare provider may have a political agenda or may be intruding into their private lives, but our patients really are very accustomed to us talking to them about all the ways that we hope they will keep themselves and their families safe. So when we plant safe firearm storage right in the middle of our conversations around things like seatbelts and bike helmets and choking hazards, and for pediatricians, these things are absolutely our wheelhouse. We make it very clear, as the previous speakers had suggested, that we are discussing this really because it has to do with our patients' health and safety and nothing else. The next thing, of course, is to always, as with any conversation, try to be incredibly non-judgmental and collaborative with our patients. We certainly don't want this conversation to harm the patient relationship that we've worked so hard to build. And also, as with any behavioral change counseling, we know that we're way more likely to affect behavioral change when we partner with our patients in healthcare decision-making rather than spewing numbers at them or lecturing them and telling them what to do. Guaranteed confidentiality is a really important one as well. I will find, in my own personal practice, I don't find my patients to be particularly concerned around this issue, but certainly many people are, and it is really important that we are prepared to always let our patients know that this conversation can stay between us. It doesn't need to go, it would not go outside of the exam room. It doesn't need to be documented in the chart. Certainly does not need to be shared with, any law enforcement or other family members. This is especially a big issue with the CARE Act and open notes. Some people might not want to know, for example, ex-spouses, for example, and might have access to the chart to know that there's a firearm there. So very important to always be sure that we're guaranteeing confidentiality to our patients. Really important, as many people have already mentioned, to be sure we educate ourselves, both around what are the local laws in our own municipalities or states, and also what is the gun culture among the families that we serve. I like to throw the Giffords.org website in any education that I do for providers because it's such a great place to really learn about all the laws in our own areas. And then again, as Kelly mentioned, it's really important whenever possible to also distribute a safety device at the point of care at the time that you're doing this education. So I think Sandy gave such a great overview. I'm not going to go through the various types of storage devices, except to say that cable locks, I think, are really probably the most practical in our clinical practices. They're inexpensive. They're very small. I ordered 1,000 of them recently from a supplier in Arkansas and have them in our storage area. Safes are more secure and also an excellent option, especially for people who need to access their firearm quickly, as Sandy mentioned. The problem is they are more expensive and they are also, larger. Like I couldn't have stored 1,000 safes, in my storage closet. So this is what our actual EMR prompt looks like that we put into the well child visit. We say as part of our safety check, and we're discussing firearm safety with all of our families. Is there ever a firearm inside your home? And we wrote this prompt very carefully. We did a lot of research into exactly how the question was worded in various places across the country where this work is being done. So some of the important, parts of the way we framed it is, number one, again, to always frame it in the context of general safety. I really like the idea of normalizing and saying we're discussing this with all of our families to really be sure that our patients don't worry that our own biases are coming into play, that we're only sort of asking certain patients whether they have firearms based on, how they look or what their cultural background is. And the use of the word ever there is really very deliberate and important. It's not just a question of whether the person owns a firearm, but also whether other people might bring firearms in. So for example, Uncle Joe has a job in security and he comes over and takes off his belt and puts it on the kitchen counter. We want a place to be able to lock that firearm up as well inside the home. So what if they say yes? This is really where a lot of people get worried about asking questions because they don't know what to do when they get the answer. I've certainly been in that situation myself as well. So what we say then is it okay if we talk a little bit about the firearm so we can be sure to keep the kids as safe as possible? Again, we're asking, is it okay if we have this conversation, remain collaborative and let the patient know that this is their visit and they get to decide where the conversation goes and set their own agenda? And then gather as much information as possible before we start doling out advice. So we want to know how the firearm is currently stored. Is it, locked, loaded, and separate from the ammunition? Also, it was really helpful to ask the reason for the firearm. I think some people feel worried about asking that question because, again, they'll feel that our patients that we're being overly intrusive into someone's private business. The truth is, I never find that to be true. I find my patients pretty open to talking about their own firearms. They seem to like to talk about their firearms. And the reason does really matter because the truth is, at least in my experience, when my families own a firearm for recreational purposes, maybe they're hunters or they go to target practice, I don't find as much of a challenge talking about safe storage with them. The families who really keep their firearm for the purposes of, being safe in case of an intruder, where they really need easy access or quick access, that they seem to have the most challenge in terms of trying to figure out how to store that firearm safely. So understanding the reason can really help inform the storage practices. So when it comes time to actual counseling, I find many of the points that I often want to make in the room with the patient, of course, are based on scientific evidence, but I personally try to avoid things like studies show. I feel like as soon as I say studies show and start quoting numbers, people get a little glazed over and I'm then set apart. I'm not a firearm owner. And I really work hard to really try to bring as much of my own personal experience and my own expertise into play. I'm an expert in child behavior and development. And so that is really what I tap into the most when I'm having this conversation. So I say things, for example, like kids are so curious. I know my own kids sometimes will go searching just to see what they'll find. And I'll give examples of times that that's happened in my life. Again, tapping into my own experience as someone who understands child development. We'll talk, as Kelly mentioned, about the fact that even a 3-year-old is strong enough to pull the trigger and fire a shot. And then I'll try to make it as personal as possible by saying that several of my own patients have found firearms that they thought were toys, to really say, even though I'm not a firearm owner, I have had these kinds of experiences. I also find it really helpful to sometimes bring in stories from the news. These are often, front page stories that everyone has heard about. In my city recently, a 5-year-old little boy shot his cousin and killed her inside their home. And everyone had heard about that story. So that can be another way to kind of bring this conversation home. And then, of course, it's very important, again, as I think some people have already mentioned too, to be sure that there's no one in the home who has a mental health disorder where the danger can really be heightened. One of the most common things I think we sometimes will hear is someone saying, like, that's none of your business. Basically, I don't have to have this conversation with you. And again, I'll just bring that right back and say, absolutely, we do not have to discuss this if you'd rather not. And again, reiterate, the only reason I'm asking is so that we can discuss how to keep the child safe. And again, this is the time that I emphasize confidentiality. Turn away from the computer, stop typing, and really just have a conversation that clearly can just be between the two of us in the exam room. One of the most common hesitancies I found around safe firearm storage in my population, I work right in urban Philadelphia, is people who need ready access for their own protection. And so I try to bring in, my initial instinct is always to bring in, or the way I was trained was always to bring in sort of, again, what the studies show, which is that we know very well that having a firearm inside your home actually increases your risk of death and injury in case of a break-in rather than protecting you. But instead of throwing that data out, I'll start by sort of explaining why this is true, which is that if an intruder comes into your home and you don't have a firearm, they might ask for the money, they might find whatever jewelry they want and get out. Whereas if they see you with your firearm, they're more likely to reach for theirs. Sometimes this works, and my patients really seem to hear me have this conversation with them. I will say other times, most of the time, my patients are just so deeply scared. Gun violence has gone through the roof in the community that I serve, and people are petrified. And the argument often really doesn't go as far as I might hope that it will. So in the case when someone is, really just petrified to go to sleep every night because of what's been happening on their block, what we do then is really try our best to offer a harm reduction approach, which basically means trying to keep that lethal weapon as safe as we possibly can. So I'll suggest things like locking it up during the day. The truth is that most intruders are going to come into your home at night. So during the day, when the kids are awake and running all around, you lock that firearm up. And if you need to, at night, when the kids are safely asleep in their beds, that might be a time to go ahead and take it out where you can get it most quickly. Again, I should reiterate again, there are lots of safes that let you access a firearm very quickly. So there are biometric safes and fingerprint safes, and that's also a fabulous option for people who want that ready access, just like Sandy said. In my population, safes are hard for people to get a hold of, and they're expensive. So I'm usually giving out a cable lock, and I'm talking about how to use this cable lock in the way that can keep their kids as safe as possible. And then I want to always be sure when someone is talking about using the firearm for self-defense that we understand the laws in our state, because the last thing I want is for this person to defend themselves against an intruder and then end up in jail, and their kids have to grow up with a parent who's in jail. So that's also a really important thing for people to be aware of. Around suicide, I have often had parents say that, they know if their child is depressed, and so they don't need to worry about that with their child. And, one of the things, and this might be what the person who was trying to ask the question wants to get at, I'm really curious to hear more of what you have to say on this. When it comes to teen suicide, I will say, many teens are very, very impulsive. And unfortunately, this is the kind of act that happens, as Kelly said, sometimes in just a few minutes. So it's really important for people to know that teens can become suicidal quickly because of a thing that happened, like they got a bad grade in a test, someone broke up with them. Sometimes suicidality comes, at the end of a long bout of depression where we're aware that this is something we're struggling with. But often it's not the kind of depression that we actually can see. And then I'll go and explain, 9 times out of 10, if the suicidal person can access a firearm, they'll complete the act. Whereas kids who try to commit suicide by doing things like taking pills or using a razor, oftentimes they'll take the pills and then they'll lie down and wait for something to happen. And then they'll realize what they've done and they'll call for help. So they manage to complete the act of suicide between 2 and 4% of the time, compared to 90% of the time. If you use a firearm, obviously you don't get that chance to change your mind. We find our patients really are receptive. I think this is a very important thing that we really want to focus on. These quotes were the result of a focus group that was done before a similar program in our emergency room in my department. At my hospital. And, our patients do see us as trusted healthcare messengers, and they do trust us to have this conversation with them in a way that is non-judgmental and that is collaborative.